It's time for another warm-up review. Let's get going. Which cell wall inhibitor matches each of the following statements? So the first one here is next step in the treatment of otitis media if resistant to amoxicillin. So you would combine amoxicillin with clavulanic acid, so it comes in one formulation. Next one, prophylaxis against bacterial endocarditis. So penicillin V is fine. Alternatively, you can use one of the aminopenicillins like amoxicillin or ampicillin, or you can use a first-generation cephalosporin like cephalexin. Next, we have sufficient for the treatment of syphilis. So this is going to be penicillin G, that's the IM or the IV form of penicillin. Single-dose treatment for gonorrhea, that's going to be ceftriaxone. Next, what is the equation for determining the confidence interval? Well, a confidence interval indicates the reliability of an estimate. And the equation for confidence interval is the mean plus or minus z times the standard error of the mean. Next, what are the Kubler-Ross stages of grief? So it starts with denial, then to anger, then to bargaining, then to grieving, or sometimes people put in depression there, and then finally acceptance. All right, that's it for the warm-up. Let's get to that video.
Hello everyone, and welcome to our Step 1 lecture on hypothyroidism. We're going to start with some basic concepts about the thyroid, and then we'll talk about hypothyroidism and the conditions that cause it. So thyroid development, definitely a 4-star topic. So make sure you're very familiar with these study guide questions and answers. So the thyroid begins development in about the 3rd week of gestation and is derived from endoderm, from the floor of the primitive pharynx. So you should know about the remnant structures in thyroid development, the thyroglossal duct and the foramen cecum. About half of people will retain the connection between the tongue to the thyroid, the remains of the thyroglossal duct, which is called the pyramidal lobe of the thyroid. And the foramen cecum is the more common remnant of the thyroglossal duct, which you'll see in the middle of the tongue. So if the thyroglossal duct remains patent, it can form a cyst in the anterior neck and the midline, which will move with swallowing. And these need to be removed because of infection risk. And one last thing on development, because the developmental connection between the thyroid and the tongue via the thyroglossal duct, the most common ectopic thyroid tissue site is the tongue. So here's a close-up of thyroid tissue. You can see the abundant pink colloid where thyroid hormone is stored and the small follicular cells in between. So let's talk a bit more about the formation of thyroid hormone. The cells of the thyroid trap the iodide from the circulating blood, and the thyroid gland has massive blood flow per gram of organ. Only the adrenal glands have more. So the sodium gradient is utilized to bring iodide into the cuboidal epithelial cells of thyroid follicle. Once inside the cell, the iodide is transported into the follicle where it's oxidized by peroxidase to iodine and then ultimately binds with thyroglobulin, or Tg, which is a big storage protein. So the binding of iodine to the thyroglobulin molecule is called organification. And the actual thyroid hormone is made within the thyroglobulin molecule by the union of tyrosine and iodine. These iodines are added one at a time, so the first molecule that's made is monoiodotyrosine, or MIT, then diiodotyrosine, or DIT. Then it's the coupling, or what is called the condensation of these molecules that make T3 and T4, much more T4 than T3 actually. And the T3 and T4 remain attached to the thyroglobulin molecule and hang out in the colloid until release. And the next step here is the proteolytic release of the hormone from the thyroglobulin in the follicle. So the follicles of the thyroid store about 2 or 3 months of thyroid hormone. In the peripheral tissues, the T4 is converted to T3. So also important to realize is that most of the T3 and T4 in the blood is bound to thyroxine-binding globulin, or TBG, and only the free hormone is active. So TBG is a measurable protein, and before we had good ways to measure free T3 and free T4 levels, that's the unbound forms, we had to keep an eye on TBG because of the impact on total T3 and T4 levels. And it's possible you could see a question on this. So there's decreased TBG in hepatic failure or nephrotic syndrome or other conditions with low protein. So with this, the total amount of T3 and the total T4 might be decreased, but the free T3 and free T4 may be unchanged. Then there's an increased TBG in pregnancy and also with oral contraceptive pill use. So you would have an increase of total T4 in pregnancy. And this can all get very confusing, and fortunately we have good measures for free T3 and free T4 now, so this eliminates a lot of the uncertainty around the total hormone levels. And another thing to be aware of is that T3 binds receptors with much greater affinity than T4. So T3 is stronger than T4, but T4 is the one that's produced in greater quantity. And this is actually a nice system. The thyroid itself makes mostly T4. This has a long half-life in the blood, 6 to 9 days. The T4 is not as active, and it acts like a circulating reservoir of almost ready thyroid hormone. Then peripheral tissues make the conversion to the more active T3, which has a short half-life, and local production makes it more specific. And there are several different deiodinase enzymes that make the T4 to T3 conversion in different tissues. So next we're going to dive into pathology with the discussion of hypothyroidism. So basically hypothyroidism slows everything down. And some resources and articles will use the word myxedema interchangeably with hypothyroidism. And that's not incorrect, but I find it a little confusing because we also see pretibial myxedema and Graves' disease, which causes hyperthyroidism. But some will just use myxedema to describe the symptoms of hypothyroidism, which is where you'll hear the term myxedema coma, which is associated with hypothyroidism. I find it easier and more descriptive to just use the term hypothyroidism to describe hypothyroidism. Clinical features of hypothyroidism include cold intolerance, weight gain, constipation, deepening of the voice, menorrhagia, slowed mental and physical function, dry skin with coarse, brittle hair, and reflexes showing a slow return phase. Fortunately, lab testing is very reliable for thyroid diseases. We screen for hypothyroidism using blood levels of TSH, that's thyroid stimulating hormone, which will usually be high. We don't generally screen patients using free T3 or T4, although these are useful for confirmation and determining extent of disease. And the reason for this is that the TSH changes exponentially to the linear changes in the actual hormone levels, so it's a very sensitive test. So as you probably recall, TSH is a hormone that's secreted by the anterior pituitary, and its job is to stimulate the thyroid gland to secrete T3 and T4. So when there's not enough thyroid hormone in the body, in hypothyroidism, then the pituitary makes more and more TSH trying to stimulate the thyroid gland, which of course isn't responding. So remember, TSH is high in hypothyroidism, and then of course the opposite would be true in thyrotoxicosis, which we're going to cover in a different lecture. So let's now go over some of the specific causes or types of hypothyroidism. Most of these will have very similar clinical pictures, like cold intolerance and weight gain and so on. And the causes of hypothyroidism all in some way result in destruction or removal of the thyroid gland, rendering it ineffective. We're going to discuss congenital hypothyroidism, antibody-mediated destruction, that's Hashimoto's thyroiditis, iodine deficiency or excess, subacute granulomatous thyroiditis, treatment of hyperthyroidism by radiation, which results in hypothyroidism, and surgical removal of the thyroid. And then there also can be thyroid destruction from neck radiation treatment for other head and neck cancers, and medications like amiodarone, tyrosine kinase inhibitors, lithium, and a few others. Then of course there can be idiopathic causes. So the first topic here is congenital hypothyroidism, which used to be called cretinism, and you can understand why that term fell out of favor. I'm sorry, your baby is a cretin. No. So anyway, there are several causes of congenital hypothyroidism. In the United States, it's most commonly from thyroid dysgenesis, which is seen in about 1 in 4,000 births. So this can be complete agenesis or absence, hypoplasia, or an ectopic location like failure of descent. Other causes include thyroid-related enzyme deficiency, dysfunctional hormone production, transport, or function, or TSH resistance. And there can be transient hypothyroidism from transfer of antithyroid medication or antithyroid antibodies from the mother. And then in other countries, the leading cause of congenital hypothyroidism is iodine-deficient diet in the mother during pregnancy. And this can be transient as well. You won't see this much in the United States since our salt is iodized and a lot of other foods have iodine naturally. Generally in this country, people eat enough variety of foods and enough salt that we have plenty of iodine intake. Deficiency is occasionally seen though. So the clinical features of congenital hypothyroidism can be significant if the disease is undetected and untreated. Many of these babies have no congenital malformations, although there can be various associated conditions. However, the longer the hypothyroidism goes untreated, the more the child will have impaired physical growth, intellectual disability, enlarged tongue, and an enlarged and distended abdomen. And because this disease is common enough, potentially severe, and totally treatable, we screen every newborn for congenital hypothyroidism. Early detection means thyroid hormone replacement can begin early. Okay, next let's talk about Hashimoto's thyroiditis. This is the most common cause of hypothyroidism in the U.S. It's an autoimmune disorder and is associated with a painless goiter. Let me say that again. Hashimoto's is hypothyroidism with painless goiter. This will come up on a question somewhere, and you certainly will see it clinically one day. Hashimoto's, hypothyroidism, painless goiter. So these patients get a dense infiltrate of lymphocytes into the thyroid gland that causes eventual destruction of all hormone production. And you can see that represented on this slide from an affected gland. All those little lymphocytes and not much of that nice pink colloid you remember seeing in the slide of the normal gland. So to diagnose this, you want to order a TSH level, which will be high, and a free T4 level, maybe even with a free T3 level, and these would be low in overt disease. You also could order antibody levels to thyroid peroxidase or thyroid globulin, which can be helpful to determine the cause once hypothyroidism is established. However, be aware that these antibodies are very common in the general population, around 25%, and a finding of antibody presence in a euthyroid patient does not guarantee that person will become hypothyroid, nor does it make a diagnosis of Hashimoto's. There's a 5-to-1 female predominance, and the incidence increases with age. It's associated with human leukocyte antigen, HLA-DR5 and HLA-B5. Hashimoto's is a type 4 hypersensitivity disease. You may see a question on that. So the clinical features will vary depending on stage of the disease. And let me clarify again on one thing. The painless goiter is the buzzword, but clinically, in order to make the diagnosis, you have to see hypothyroidism as well. Just a goiter is not Hashimoto's. Early in the course, if you looked, you would see a euthyroid state, and you might measure a positive antibody with normal thyroid hormone levels and normal TSH. This would be asymptomatic. I'll say again that some patients with positive antibodies never progress to any thyroid dysfunction and others do. As the inflammation begins, there would be destruction of thyroid follicle cells, and as that occurs, there's spilling of T3 and T4 into the blood, and thus you sometimes would see a transient hyperthyroidism. Most of the time this phase is not measured clinically, and in most cases wouldn't last more than a few months. As there's more thyroid gland destruction and then infiltration of lymphocytes, hormone production declines and the patient becomes hypothyroid. So early on the gland will be enlarged, the painless goiter, but after a while patients would develop a scarred and shrunken gland in the hypothyroid state. This would be years in. Microscopically at this stage, the gland will resemble a lymph node. So Hashimoto's is very common, as I've said. It can occur in isolation, which is most of the time, or it and other autoimmune thyroid diseases can occur as part of a polyglandular autoimmune syndrome, in which it would be associated with some other autoimmune diseases or perhaps other things, commonly Addison's disease, celiac disease, type 1 diabetes, pernicious anemia, vitiligo, Sjogren's syndrome, and then many others. Also, patients with Hashimoto's would be in an increased risk of a B-cell lymphoma of the thyroid gland. So if you see a question about a Hashimoto's patient with a rapidly enlarging thyroid mass, then think about a B-cell lymphoma. All right, next I'm going to cover subacute thyroiditis. So similar to Hashimoto's, patients tend to be thyrotoxic in the early stages of the inflammation as the follicles release all that pre-made stored hormone, and then can become hypothyroid in the later stages of the disease as the thyroid is unable to continue production. So interestingly, this disease can also cause a transient thyroiditis that doesn't progress to hypothyroidism. So the difference here is the mechanism, which is lymphocytic infiltration in Hashimoto's and granulomatous inflammation in subacute thyroiditis. In fact, this disease is also called granulomatous thyroiditis. And then the other name, of course, is the eponym Deucrivain. Subacute thyroiditis often will present with hypothyroidism with a painful goiter. So don't forget, hypothyroidism with painless goiter is Hashimoto's, and painful goiter is subacute granulomatous or Deucrivain. So it's thought that subacute thyroiditis is triggered by viral infection with Coxsackie virus, echovirus, adenovirus, measles, or mumps. So in a test question, you might have a scenario where a patient has a viral URI and then develops hyper or hypothyroidism. Patients will be sick with fever, and again, they'll have a painful goiter. And in some lucky patients, this disease is self-limited, just a transient thyroiditis, and patients will return to a euthyroid state and may not require much treatment. So the treatment is directed at providing relief from the thyroid pain. NSAIDs and sometimes steroids are helpful for this, and then if hypothyroidism develops, it's most likely permanent and thyroid hormone replacement should begin. So there's also Riedel's thyroiditis. So here there's a chronic inflammation of the thyroid, which is then replaced by fibrous tissue. So in this case, patients can be hypothyroid or they could be euthyroid. So how does it present? Well, there's a fixed, hard, rock-like thyroid and a painless goiter. So if you see macrophage and eosinophil infiltrate, that's Riedel's. If you see lymphocytic, what is that? Hashimoto's. And granulomatous, that's subacute. Another important point here is that not only will patients have the fibrosis of the thyroid, but they may get extension of the fibrosis into local structures like the airway. So if you get a question about a young patient with a rock-hard thyroid and extension of fibrosis into adjacent structures, then think about Riedel's thyroiditis. If it's an older patient, then you may need to think about cancer, especially anaplastic cancer of the thyroid, and we'll talk more about that in another video. Let's wrap up this section with treatment of hypothyroidism. So usually this is easy. Just replace the missing thyroid hormone with a synthetic but bioidentical thyroid hormone like levothyroxine, which is T4. And then there are others. So let's go through these pharmaceutical thyroid hormones in a little more detail. So first, as I mentioned, is levothyroxine. This is a synthetic analog of thyroxine, which is T4. The levo, as opposed to the dextrothyroxine, you know how molecules can face right or left. Well, these only face left. So anyway, if it's dosed properly, it has no side effects for the most part and just makes people normal. That is, if they were normal before the hypothyroidism. If the dose is too high, it creates an exogenous thyrotoxicosis, and the side effects include tachycardia, heat intolerance, tremors, and arrhythmias, just like with hyperthyroidism. One clinical pearl to know is that when you're starting an elderly patient on levothyroxine, you always want to start with a low dose because you want to give the body, particularly the heart, a chance to get used to this higher metabolism slowly. And the elderly are more likely to have tachycardia or an arrhythmia, even with properly dosed levothyroxine treatment if it ramps up too quickly. Next, there's triiodothyronine, or T3. Again, this is a synthetic analog. Let's talk a bit more about this one, which we use clinically less often. So if someone is hypothyroid, aren't they low on both T4 and T3? Well, the answer is yes. So do we have to give both T3 and T4 replacement? So as I just said, most of the time the answer is no. We use levothyroxine much more often than triiodothyronine, T3. So as it turns out, and I've said this before, the thyroid itself makes mostly T4, which is stable in the body for 6 to 9 days once it's released into the bloodstream. And then the deiodinase enzymes that convert T4 to T3 are in the peripheral tissues, and T3 is more active but only lasts a few hours in the blood. And this is a nice system, as I've said, where the reservoir of T4 can be converted into T3 in peripheral tissues when and where it's needed. So it's easy to understand that replacing T4 with levothyroxine is a more physiologic and stable method, and this tablet can be given just once a day. Triiodothyronine is unpredictable with its action when given by mouth, although it is sometimes used in combination regimens with T4, and some people feel it's helpful for mood, although this is controversial. All right, so let's pause the video and look at the end of session quiz, and then we'll go through the answers. First question, what's the most common location for ectopic thyroid tissue? The tongue. Next question, how would pregnancy affect serum thyroid hormone levels? So in pregnancy, thyroid binding globulin is elevated because estrogen upregulates thyroid binding globulin, TBG. So in pregnancy, there's more TBG, and that binds up the circulating thyroid hormone. So the body senses that free thyroid hormone is dropping, and the thyroid releases more T4 and T3. So total T4 and total T3 are higher, but the free T4 and free T3 stay closer to the normal range. And the TSH can also be low, which is due to its similarity to HCG, which is a placental hormone. Next question, what are the causes of congenital hypothyroidism and how can it be prevented? So first are the structural issues, complete agenesis or absence, hypoplasia or ectopic location like failure of descent. Then there are problems with hormones themselves, thyroid-related enzyme deficiency, dysfunctional hormone production, transport or function, or TSH resistance. Then there are problems related to the mother, like transient hypothyroidism from transfer of antithyroid medication or antithyroid antibodies from the mother. And then in other countries, the leading cause of congenital hypothyroidism is iodine-deficient diet in the mother. And the second half of this question, prevention. So we might not be able to prevent all the causes of congenital hypothyroidism, but adding iodine to the diet of mothers can prevent iodine deficiency in pregnancy. Now, of course, the iodine is added to salt and is also present in prenatal vitamins. Then the other thing is identifying congenital hypothyroidism early in the newborn so that thyroid hormone replacement can begin. Next question. A 35-year-old woman has a diffuse painless goiter and hypothyroidism. What is the most likely diagnosis, and what are the most likely relative values of TSH and thyroid hormones? Well, you know from the painless goiter that this is likely to be Hashimoto's disease. In this, the TSH will be high and the thyroid hormones themselves would be low. All right, that's the end of our lecture. See you next time.
Since when does the cafeteria close at 9? I'm so hungry. Dude, Dr. Wilkerson was all in my face today. There was this patient that stopped his thyroid pills or whatever, and now his cholesterol is high or something. Wilkerson was all like, Dr. Todd, what labs would you expect to be elevated in this patient? It's all like, TSH? Because I don't have a freaking clue, you know? And Wilkerson totally flipped. He was like, Dr. Todd, if you had done the assigned reading, you would know that hypothyroidism will cause elevations of both LDL and total cholesterol. So anyway, I guess I won't be asking him for a letter of recommendation. I'm pretty much hosed, dude. I'm going to end up doing a residency in Timbuktu, you know? Dude, I am freaking starving. Are you going to finish that sandwich?